Hello and welcome everyone to the fourth day of the 8th annual MQ Mental Health Science Festival. MQ Mental Health Research is a leading global mental health charity that has invested over $25 million into research over the last 10 years. My name is Parisa Mansouri, and my pronouns are she and her, and I'm program lead at research team of MQ Mental Health Research Charity. This year's festival has been organized by an international and multidisciplinary organizing panel, including 8 people from 6 countries, collectively bringing a wide range of expertise, including mental health activists, academic, lived experience experts, policy advisors, all led by the fantastic chair of this year's festival, Helen Fisher. A huge thank you also goes to Wellcome Trust, who funded this year's festival, allowing it to be completely free to all. 400 delegates registered and are attending different sessions from around the world over this one-week festival. The aim of this year's festival is convening different disciplines and sectors to collaborate and share research and learnings to progress the field of mental health science. All the talks and panel discussions will be recorded and will be made available on MQ YouTube channel. We are delighted and excited to have an international and diverse audience here today and throughout this week, including people with lived experience of mental health problems, researchers, from all career stages, mental health practitioners, representatives from NGOs, community organizations, funders, and many more. You will notice that throughout the festival, we will be referring to people without professional titles, and this is to make sure that everyone in this space feels an equal contributor, and we hope everyone will feel welcome here. So also when commenting, please do remember that we have a really diverse audience watching today, including people with lived experience of mental health problems. So let's try to be really mindful of the language we choose to use and be respectful of everyone when commenting. If you're on Twitter or other social media platforms, we are keen to hear your thoughts on the talks and discussions. Please use our hashtag MQ Mental Health Science. You can find it in the chat as well. Today, our colleague Hala Rashidi is doing a Twitter takeover of MQ Twitter account, so do check them out. So in our different sessions today, we will be looking at the fact that people with severe mental illnesses pass away on average 15 years earlier than the average population and the general population. We need coordinated, evidence-based action to address the tragedy of people being gone too soon. So today we will be discussing topics that some people might find upsetting. Please feel free to turn off the sound, step back at any point you feel you need a break. And as I said, all the talks and discussions will be made available online, so don't worry at all. You won't miss anything. If you feel you need some extra support, do check MQ's Get Help page on our website, where you can find a list of resources and helplines. We will put a link to this web page in the chat for you. Do check it out if you feel you might need some extra help and support. During the talks and panel discussions, we are in a Zoom webinar format. While you can turn on your sound or camera, please make use of the chat and Q&A boxes. At the end of today's webinar, we will have the opportunity to move to a breakout space where everyone will be able to turn on their cameras and speak to each other. And some of our speakers will also be there and some of our panelists, so you will have the opportunity to ask your questions directly from them as well. We will share more detail later on about how to join that one. For now, please add your questions to the Q&A box. I would also like to encourage everyone to introduce yourself in the chat by answering 3 questions. What's your name? If you want to share your social media handles. And question 2, which part of the world you are joining from today? And question 3, what do you think is the biggest challenge or biggest opportunity in addressing the premature mortality and mental health? Without further ado, I would like to introduce our festival chair, Helen Fisher. Helen is a professor of developmental psychopathology at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, UK. Helen's research focuses on early risk factors that predict the development and persistence of psychotic experiences in childhood. We are delighted that Helen has been an MQ fellow in the past. She has also received several other national and international awards, including a recent Emerging Leaders Prize in Adolescent Mental Health from the UK Medical Research Foundation. We are excited and delighted to have Helen Fisher as the chair of this year's MQ's Mental Health Science Festival. Helen, over to you.
Thank you so much, Parissa, and really fantastic to be here. A very warm welcome to everyone from me to the day 4 of the MQ Mental Health Science Festival. I hope you've been joining us for the other days, but if not, please do go back and watch on the MQ YouTube channel. But today our international panel of experts will look at premature mortality and mental health, such a huge issue as Parissa has already outlined. We'll include talks and discussions on having multiple long-term conditions and mental health illnesses, as well as on suicide. And as Parissa pointed out, some people might find these topics upsetting. So if you feel you do need some support, please do check out MQ's Get Help page, where you can find a list of resources and helplines. And there's already a link to this in the chat. So our first session will be chaired by Lee Milligan, who is CEO of MQ Mental Health Research, the UK's largest charity funding mental health research. He is also chair of the UK Mental Health Research Funders Forum, a member of the all-party parliamentary group on a fit and healthy childhood, and is the independent chair of Collective Voice. So without further ado, I'll hand over the mic to Lee, and a very warm welcome to you.
Thank you so much, Helen, and welcome everybody. I'll be chairing the first symposium today that will be looking at early mortality in the context of comorbidities, so the linkage between mental health and other long-term conditions. Our second session will be looking more specifically at suicide, but we recognize that there is a real interlinkage between these two subjects and that we don't want to lose lessons of exchange by siloing these. So we'll talk more about that as we move forward. I'm really excited to introduce the first speaker of this symposium. So Fiona Gaughran will be talking to us. She is a professor of physical health and clinical therapeutics in psychiatry at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. She's also director of research and development at the South London and Maudsley NHS Foundation Trust here in London, where she's the lead consultant for the National Psychosis Service. Fiona, welcome. Over to you.
So thank you so much for inviting me to come and speak here today, and I'm delighted, and I'm also delighted with the priority that MQ are giving to this topic. It's been a long-standing priority of my own, and life. You know, I spent my life working on it to an extent. So I'm really pleased to see your interest, and thank you very much. And I suppose we're hoping to see, what do we need to do? We've established this as a problem, and I'll talk a little bit about that. But what options have we to help reduce the size of that problem, help make things better? So we pulled together a Lancet Commission. I've got 5 minutes, so it's very quick, just about 3 slides. We've pulled together a Lancet Commission with a group from all over the world there a couple of years ago, looking at what the issues were. And I'm going to start with the left-hand side of this slide. And then I'll come back to the second half in a minute. What are the quick wins? The quick wins are that we have people who have significant mental health problems. That's probably smoking about 3 times as much as people with in the general population, which contributes massively to poor health and to premature mortality. Our systems have supported smoking cigarettes, and the biggest, quickest win is to really work hard on helping people give up smoking. But of course, that is part of a whole package of health promotion initiatives, which we don't really know how to do effectively yet, and we don't do enough of. It takes quite a bit of input. With some areas where they can put in health promotion activities at the very beginning and prevent weight gain, prevent that deterioration in cardiometabolic risk. But that's not widespread and it is quite expensive. So how do we integrate that into practice to make sure that we are encouraging people to eat healthily and exercise more? You know, we all find that really difficult. And sometimes if people have a significant mental health problem, it's even more difficult than that. So how do we help people get over that additional hurdle? Medication is really important. And it's two things. It's, you know, making sure that that if we're using medication, that people are on the lowest effective dose so that the side effects are minimized. And side effects are a significant worry for weight gain and cardiometabolic risk in particular, also potentially bone health. But the other thing is that actually we need medications to do their job. So some people have a mental illness that, you know, some people have mental illness that can actually respond without medications, but many, particularly with people who are going more into the significant psychotic disorders, will need medications. But it's important that you're getting one that works for you, because actually the most important thing is that to be able to manage your own mental health. And I think that's an area we haven't looked enough. Sorry, your own physical health, that your mental health is good enough to be able to manage your physical health. So that's, to me, a really important goal of treatment, that somebody is able to move towards more autonomy, because we know that being on antipsychotics longer term actually halves your risk of early death from heart disease and from physical health problems. So yes, there are side effects and that's a problem, but untreated illness gets in the way of autonomy, and that's something we really need to manage. And then of course the problem is, well, we know that sometimes, you know, being unwell prevents you accessing treatment easily, and our systems don't respond to support that. They're fragmented, they don't talk to each other, and they don't adapt quite as easily. So those are big issues. And in that, we've been very aware of cardiac risk, of weight gain, of sugar problems, of lipid problems, but actually it's every single system in the body. Every medical chapter in the textbook is compromised by having a concomitant major mental illness that in some way or another might get in the way of you understanding there's a problem, telling somebody there's a problem, working with somebody to go and help that problem, even if it's just difficulty in coordinating yourself to get out to appointments, and then difficulty in, maybe there might be difficulty in working with the team to be able to respond to the recommendations to manage whatever your physical health problem is. And that applies at every level of healthcare, at prevention, in primary care, in secondary acute care services, in mental health services, either secondary or tertiary. How do we help people access appropriate healthcare at every level, flexibly and communicating well? There's a universal disadvantage at the moment, but there's loads of scope to get by that. And then finally, looking at the second half of this slide, what can we do? Well, again, that's at every level. Looking at every level of healthcare, as I've outlined, but also then looking at policies and commitments and partnerships. So, for example, we work in King's Health Partners, and I've seen a massive difference since the mind and body was made a priority. Our physical health colleagues are really keen to work with their mental health colleagues to see can we get better care, but also larger public health and preventative medicine addressing behavioural risks and early intervention, so that before the weight goes on, before any problems arises, we're talking to people about how to prevent that and working with their families and themselves to empower them to be able to take that knowledge and priority to every clinician they see. We need to improve our prescribing, again, like that, not just the prescribing of psychiatric medications needs to be on target for what it's intended to do and with the minimum amount of side effects for the shortest possible dose and the shortest possible time. But also prescribe and make sure we have good access and treatment for whatever other physical health problems are going on. I've mentioned about integrating access, and I'm also going to mention, just tantalizingly, digital can help in the future. There's lots of digital scopes there, but access to digital isn't universal. And we need to make sure that we're not relying solely on digital, where sometimes people may suffer from digital exclusion. And I'm going to stop there and stop sharing my slides, as I've probably run out of time. And thank you, and just say thanks to all these people who we do our research with, most of which I haven't had a chance to present today. And thank you very much for inviting me.
Thank you so much, Fiona. A whistle stop tour, but loads in there that we'll get to in the panel discussion. We'll come to our second speaker of this symposium. We'll now be hearing from Carol Worthman. Carol is the Samuel Candler Dobbs Professor Emerita of the Department of Anthropology at Emory University in the United States of America. Carol's work integrates anthropology, human development, and neuroscience to investigate the base of differential well-being with a particular focus on adolescent and global mental health. She is also the recipient of the Society for Psychological Anthropology Lifetime Achievement Award in 2021. Carol, over to you.
Thank you, Lee. I'm going to share the screen now. I say hello to everyone, and thanks for joining us in this discussion of a really important topic. And actually, we always know we're on to something if people converge on similar messages. So I think you'll be interested to notice how what we're discovering is converging with what Fiona has just discussed. What I'm going to tell you about this morning is the Gone Too Soon initiative within the MQ, and specifically, I'll be talking about the mental health aspect of the road mapping we've been doing on the sources and solutions for premature mortality. And before I get started on that, I want to acknowledge the work of so many people, including the steering committee, as well as the MQ staff and IFM Engage, who is the consulting firm that has helped us with the road mapping process. So let me tell you about that process and what we've been doing to approach this problem in terms of first gathering knowledge, then trying to prioritize the issues and the potential solutions with a focus on translation to action. And there were two arms to the early mortality problem. One are the comorbidities associated with mental illness, and the other is suicide. Now, Rory O'Connor is going to be talking to you about our initiative regarding suicide, and I'm going to focus on the mental illness aspect. And for this exercise, we've been using an eco-social framework so that we can look across the spectrum of the society, from the individual through relationships on to communities and the structural. We set out with a series of questions to address for our information gathering process vis-a-vis mental illness. The first question is, why do people with mental illness die younger? And why don't people with mental illness get the help that they need for their physical health? And what role do comorbidities play in premature death? And the road mapping process we pursued involved a multi-step process. First, we recruited a whole set of experts globally across disciplines and lived experience. And we engaged them in a process of information gathering. First, aimed at the three questions I just told you about, we asked them to complete worksheets on factors and solutions involved at each level of the eco-social framework that I just showed you. We then consolidated this massive input to identify key themes and cross-cutting factors to look for solutions. In the first online workshop, we identified priority factors through working subgroups that focused on the different domains of mental illness and suicide. And after that workshop, we consolidated the discussions, put together the scoring for the priorities, and then scored solutions on their impact and feasibility. Then we went into the second virtual workshop to discuss priority solutions and focus in on steps and barriers to implementation. After that, that is the steering committee, worked on identifying unique and common factors in both domains of mental illness and suicide with a move to action. So why do people with mental illness die early? Well, you've just heard many of the reasons. Top were multiple medical comorbidities, as well as ostracism and stigma. In this slide, what I'm showing you in black icons are the issues that are strong elements, and in gray are the issues that are inadequate. So low investment in mental health services, poverty, homelessness, poorer care than in the general population, delayed detection of illness, reduced self-care and diagnostic overshadowing were all lacks that we discovered. Increased exposure to risk and victimization, structural barriers to social inclusion, and substance abuse were major factors in dying early. But then the next question was, well, why don't people get the help that they need? And here again, stigma and discrimination were major factors. Have you heard the siloing, the separation of mental health and physical health, compartmentalization related to this of physical health and mental health, diagnostic overshadowing, where persons with mental illness who present with physical problems, it's attributed to their mental health problem. But then we also have the problem of reduced social networks, limited financial resources, limited investment in mental health, and associated lack of mental health knowledge among providers, and the need to tailor treatment in a global setting for issues of literacy, numeracy, cultural appropriateness. And finally, the associated problem that programs that are aimed at improving health are not designed necessarily for people with mental illness. What we were impressed by was in doing this exercise targeting both mental illness and suicide was that a whole suite of cross-cutting factors emerged. So all of the 9 issues that I'm showing you here were shared. Stigma and marginalization, issues of belief, norms, and knowledge, isolation, trauma, inadequate resources, fragmented care and siloing, substance use and abuse, and person condition specific dynamics, and as well as cross-cutting features, especially stigma for comorbidities and mental illness, were major cross-cutting factors. This is exciting because it means that by addressing one of these issues, we can hit across all of the dimensions of the social ecology. So what were the actionable solutions that we identified? There were 3 principles that emerged. First, the need for integration of mental and physical health care. And here I'm excited to say that a lot of solutions are available or being worked on right now. And much of that exciting work is happening around the globe, not in just in higher income countries. A lot of work on improved provider training, overcoming bias and stigma, primary care services that can handle mental as well as physical health, reduce physician bias and overshadowing, better screening and prescription for comorbidities. Second principle is prioritization of prevention. So you've already heard regulate tobacco, support adequate nutrition, turns out to be an important feature, and community-based interventions. Third principle, the optimization of intervention strategies, had a lot to do with support and particularly overcoming poverty and marginalization. So reducing income inequality, providing cash support and transfers, increasing investment in mental health, and reducing stigma, discrimination, and gender violence. All of these are to be mobilized in at each stage of the intervention cycle, from prediction, early detection, diagnosis, personalized management, treatment, and prevention, the full cycle. And I'm showing you a sketch now that has been developed by our lived experience experts who are pointing out that lived experience can be at the center of what we do, driving the engine of change for better intervention across, as I said, the eco-social framework. And to conclude, this isn't just an empty exercise. Action is associated with the roadmap, and this is what we're really excited about. The factors and solutions that we have identified are being shared out in a full report, a forthcoming Lancet article, and thanks to MQ, a suite of funding opportunities for research and for scholars. So stay tuned, and thank you, MQ, for the work you've been doing in this sector.
Brilliant. Thank you so much, Carol. We're now going to move into our panel conversation. We've got Fiona, we've got Carol, and I'd also like to introduce Louise Ting to the group. Louise Ting has extensive lived experience of accessing mental health services and has also volunteered for a number of well-being related charities over the last 10 years. She's contributed to the design of an award-winning self-harm advice application, the recommissioning of regional mental health services, reviewing funding applications for mental health research and applied research governance at a strategic level, all from public patient involvement perspective. Louise is also a member of the HDR UK funded DataMind Research Advisory Group. Louise, welcome to the panel. If you've got questions, please do drop them into the Q&A. I will kick off with a few here. It feels like across both of those presentations, this bi-directional, this two-way link between physical and mental health is also really wrapped up in the economics. So where people's social and economic status is at. Does that mean that this is like fundamentally not a medical problem to solve? Is this, when we say a public health measure, is this just a poverty issue first and foremost, or how do we break that down? Fiona, I'll come to you first and then Carol.
So poverty, disadvantage, inequality, all hugely important drivers. They are hugely important drivers for the general population too. And I think that they can and are people with particularly significant mental illness are more affected by those. So there is definitely an amplified effect in our group, but it is not the only problem. I think it's amplified then by features of the illness itself that might actually get in the way of accessing care or taking up care. Amplified by the sort of diagnostic overshadowing that Carol gave in a brilliant talk. Thank you for that, and how we respond to those things, both at an individual sort of clinician-patient level and that dyad and stigma affecting things, but also at a system inflexibility problem, because the systems are aware of population inequalities, but still probably have inadequately adapted to those. But any adaptations they've made have not dealt with this sort of partner inequality of having a major mental health condition. So I think absolutely hugely important, and if we could solve those, that would help enormously, but not the only problem.
And Carol.
Yes, I agree. I think it is important to recognize the major impact, not just of economics, but of social ecology. So I want to remind you that stigma and discrimination is a huge issue everywhere. And it cuts across all the levels, so that not only are families with family members who live with mental illness stigmatized, but care providers are stigmatized. Psychiatrists are at the bottom of the status hierarchy, not to mention all the nurses and the other carers who are involved. So not only are they underpaid and under-resourced, they're also underappreciated. But this is what's so exciting about this moment, I have to say, that one of the few upsides of COVID is that we have recognized the integral relationship between mental and physical health, and that actually mental health is everyone's problem. And the last thing I would say is to reinforce what Fiona pointed out, which is that mental illness is a problem that could afflict anyone, whether you're rich or poor. So just adding resources is not all there is to it, and reworking the healthcare system, which again, this is our opportunity. Our systems are a little bit on their knees. So rather than look at this as a problem, we can look at it also as an opportunity for necessary structural change.
Brilliant. And I suppose, touching on that point, there were studies that came out at the start of the pandemic or midway through the pandemic. I think Max Taquet and John Getty's group did a piece of work on US and UK healthcare records, and they pointed this bi-directional link between having a serious mental illness diagnosis and then contracting COVID, or contracting COVID and then quite quickly after that being diagnosed with a mental health condition. So obviously not access is the biggest challenge there in terms of healthcare services. And you both point to primary healthcare presentations as areas for reform in the system. I suppose the question is, how do we challenge, or how do we improve that primary care access to have a full whole person mental and physical health approach? That do we have ideas on how that can be done? And Louise, perhaps as well, some of your reflections on engaging with services. Where do you think the gaps are in this understanding of a person as mental and physical all in one? Over to all three of you.
So if it's all right for me, just to start off, because I wanted to say that I very much echo all the opinions that have already been expressed in this panel around the complications of how do you actually access the right mental health support, and how does it join up with physical health care. But on top of that, how a lot of the time inequalities do occur within, for example, areas of social deprivation. And so one thing I wanted to touch upon from my own experience actually is how underrated it is to listen to the individual needs of the patient. And what I mean by that is, because it's very complex, people are actually very different in how they respond to their circumstances and how that interplays with their health, both on a mental and physical level. And sometimes we need more joined up services, but other times it can just be as simple as a clinician listening to what your very distinct needs are and tailoring their approach. So an instance that I can give has actually happened to me recently is because of my mental health, I am disabled and I live in council housing. And at the moment, I've found out that it's actually been very poorly maintained. As a result, they are going to need to move me. And I think it's quite easy for professionals to kind of, I guess, consider this a problem of safety. But what they haven't actually done is look beyond that and spoken to me and said, how can we make this process easier for you? What are your anxieties right now? Because as a consequence of being told this news, it isn't just I'm living in somewhere that is dangerous for me to continue staying in long term. It's actually around how now it's triggered my post-traumatic stress disorder. My stress levels, my anxiety, my depression, all of those have worsened. And some of that has actually been avoidable in that, for example, if I'd had more information communicated to me or in a more timely manner, or just being told what to expect so that I'm not kind of staying up at night wondering and not knowing when someone's going to contact me next about the kind of latest update, for example. And so I think that obviously you could say that looking at my particular circumstances, it doesn't help that I'm living in this poorly maintained housing, and that is due to social deprivation. But then there are also simple things that are kind of a more holistic approach, which is around looking at not just what's the safety of me in my own home right now, but actually what is the impact of my mental health, my physical health, and how can even my housing officer, for example, communicate the right information to me in a way that alleviates my anxiety and distress. And so I think that a lot of this does come down to also making sure that services are joined up and everyone has a holistic context, that kind of lens to look at an individual and say what matters to you most right now and how can services be tailored to fit what your needs are, and understanding that that can be unique for everyone.
Thank you, Louise, for that impassioned explanation of your situation. It sounds brutally hard, but I think you've made an incredible point there, and there's a lot of comments coming in about that. Fiona.
I've just, I absolutely agree, Louise. I think that's so important and a really sort of a helpful example. It makes me think of some work, and there's evidence to suggest that the approach you're talking about is helpful. I don't know if you're aware, you're possibly aware, the work that Khalida Ismail did looking at the 3D, 4D project, where she had developed an integrated care package for people with diabetes, which included not just the diabetology stuff, but also input from psychiatry and mental health, but also input from housing. And she was able to show benefit of that. So it's a really, what you say is really meaningful. You asked a comment about, about systems and primary care, and I think, Louise, then again, you really amplified that, that there's variation, that everybody's individual, and I suppose, and that is the big challenge in being able to say, how should we do this better? Because actually the amount of support that people need varies from person to person, and for individual people may vary over time. So sometimes they don't need any support, really, they can get on and manage it all themselves, and sometimes actually they need a bit more support. And so how do we create a system that's flexible enough? What I tell my colleagues when they ask me, or what I tell people who ask me that is I think that actually the standard should be standard care. That everybody, and I suppose that's easy to define in the UK. Carol, you mentioned the US health insurance impediments. In the UK, there is a standard of care, and we should be aiming towards that. Everybody gets that, but we should be keeping an eye to make sure that if people aren't able to access that one way or another, and that there's support to be able to do so, and adaptations available when needed. And it's that flexibility, that adaptation thing that I think is really difficult to create a generic recommendation for. Having said that, there's sort of incentivization approaches that they've done both in primary care and in secondary mental health care to be able to look at, say, actually, we need to monitor, we need to check every year whether somebody has just simply their weight and their sugars and their blood pressure done. Has that happened? Well, that's helpful, and having a care plan with your GP and going for those annual physical health checks have actually been shown population-wide to reduce the risk of turning up in the emergency department, or even of having a serious mental illness admission, even though it's a physical health check. So it has, and to have health economic benefits, so it's wider. So that's, I think, so it is important to sort of take that dual approach, that we need to flex for the individual needs, but also we need to set population service standards. And then there's the question of, and all of it needs to bear in mind the sort of intersectionalities of risk that people have when you have socioeconomic deprivation, diversity in terms of the increased risk for some racially and ethnically minoritized groups, how those add together to increase your risk for some physical health disorders, some mental health disorders, and how that might work together to affect outcomes, process, and access to care.
Brilliant. Thank you, Fiona. We've just been joined by who was meant to be our third speaker on this panel, but we've had some technical challenges getting in the webinar door, but welcome Ethel. Ethel Mpungu is a researcher and clinician doing innovative work in mental health and HIV in sub-Saharan Africa. She's a senior lecturer and psychiatric epidemiologist in the Department of Psychiatry at Makerere University College of Health Sciences, and the head of the Consultation Liaison Psychiatric Service at Mulago National Referral Hospital, Kampala, Uganda. Ethel, welcome to the panel. I won't pose a question at you straight away. I'll give you a few seconds to get your feet in the door. We're just discussing the challenges the challenges to access services where people have dual physical and mental health conditions, and they're also then suffering from socioeconomic deprivation and aren't able to then necessarily access the services they need. And specifically, we're sort of challenging this idea of how do we make change? How do we change the system? Carol, what were your reflections on that? And then Ethel, I'll come to your context.
Well, in some ways, I'd like to hear, Ethel's thoughts on this, because I think there's a lot of creative work, even though we may say that low and middle income countries are facing enormous challenges, which is true in terms of resources and systems limitations. There's a lot of creative work going on out there that we all can learn from. So over to you, Ethel. Sorry.
Thank you so much. Thank you so much, Carol. And hello, everyone. Thank you for joining us in this conversation about mental health and premature mortality. For the past 2 decades, I and my colleagues have documented the burden of depression in persons living with HIV/AIDS. And the challenge really has been that mental health care has not been integrated into the HIV care system, which we all know is a very elaborate and well-funded healthcare system. But unfortunately, mental health care was missed out. And so persons HIV have not been receiving mental health care problems like depression, anxiety, clinics, but their mental health problems are undetected and therefore undiagnosed and untreated. And what has been happening? So the depression or the anxiety, it progresses until it becomes severe. And when somebody has severe complications like suicide, attempts suicide, then the health workers become alert and they say, there's a problem. Okay, so what do? They simply say, refer to the National Mental Hospital. So that has been the challenge, the lack of recognition by the HIV experts that mental health care is part and parcel of the care that should be given to HIV, to persons living with HIV/AIDS. So over the years, we've documented the burden to show that these problems are significant and they're affecting the treatment outcomes of these patients. Patients are unable to adhere, and subsequently they cannot suppress the HIV virus. So we have gone on to develop culturally appropriate group support psychotherapy, which we can now use as a first-line treatment for depression in HIV clinics. And at the moment, we are training all health workers and all health workers in the HIV care system. We are currently having a national training of trainers, and that's why I was unable to join in time, because we're now training them to recognize depression and then be able to respond by giving group support psychotherapy, which we have shown to be highly cost effective and highly effective in treating depression and also improving the HIV viral suppression. So we hope that going forward, if we integrate this into existing HIV care platforms, we'll be able to reduce the mortality associated with HIV/AIDS, but also be able to prevent HIV transmission.
Fantastic.
Thank you, Leah. Over to you.
Fantastic, Ethel. Thank you so much for summarising what is a huge piece of work in an incredibly tight way there. And you've actually touched on a point that came through as a question to the panel. So the question was looking at to advance these sort of holistic approaches in health, we need to obviously do more in advocating effective policy. And the question is essentially, how do we do that alongside other health agendas? So rather than leaving mental health siloed into one space, how do we do that? And that sounds like exactly what you've done, Ethel, in your context, is worked alongside other health professionals. What advice would you give to other nationalities and other nations represented today about how you work alongside those other medical professions to drive change?
Yeah. Thank you so much, Leah. Of course, it's very, very important to collaborate with all stakeholders. I think our key turning point was really in making a decision to work with the Ministry of Health, collaborating with the Ministry of Health, but also other implementing partners in the HIV care. We collaborated with the AIDS Support Organization, one of the largest organizations supporting people living with HIV/AIDS with different branches across the country. And we were able to show that it is feasible to train healthcare workers to recognize depression and equip them with basic counseling skills, that they can then use to push back mild to moderate depression. So it was really key in working with the other stakeholders, because when they are part of the process, then it is very easy to implement the interventions once proven effective.
Fantastic. Fiona, I'm very aware that you have got a hard stop and have to head somewhere else. Let me come to you for a final comment before you dash off. I don't want to make this too trite a question, but if you were sitting in front of the Chief Medical Officer of the UK and beside him was whichever Chancellor we've got at the minute, and you were putting down one demand between the two of them, so they've got the money and you've got the CMO, what is your demand and how do we move forward this agenda on comorbidities?
I'd like them to bring in the Chancellor and make sure we're not going too far down the austerity route for starters. But on the medical side, what I'd really like is to have every general hospital trust having to prioritise mental health, and every mental health trust to prioritise physical health, so the two are not running separately.
Brilliant. Thank you so much, Fiona. If you dash off, I really appreciate your time. Thank you. Carol, let me come to you as well then. You've got the US equivalent of the Treasury Department, and you're flanked by the National Institute of Mental Health and whoever else you need in that room, and you're sitting in front of the right people. What's your demand? What's the one thing we've got to push for above all else?
National health care would be a start. We have a major problem of finances and insurance. The United States spends more money per capita on healthcare with less impact than anywhere else in the world. It's a massively inefficient system. With all due respect to the dedication of myriad care providers, it's a system that really does not work well for the benefit of most people. So one of the things to point out is the inefficiencies in this system. We could be smarter and use our resources much better through not just throwing more money at it, but kind of structural changes that we've just been talking about. And as part of that, reductions in wealth inequalities that we've also discussed as some of the psychosocial root causes of suffering as important.
Brilliant, thank you. And Louise, if I come to you, in your context, we've got a meeting set up, and the Chancellor's about to announce the new budget in about 4 weeks' time. What are the priorities from where you're sitting in terms of health and mental health? What would you want on that list, on that docket?
I don't want to repeat exactly what's already been said, so I think I might kind of elaborate on an aspect, which is having standardized processes and systems, because I think that will, for example, allow conversations to be held in a way where you actually do end up addressing all these different aspects and how they come together in a way that intersects and all contributes to that holistic context that I placed so much emphasis on before when talking, in the sense that Fiona mentioned how you can kind of have a dual approach whereby you actually collect things such as heart rate, blood pressure, or these kind of maybe more physical measures, as well as actually listening to the patient and understanding what's important to them, how their lifestyle is, what changes they want to make, giving them information on how they can do these things in a way that works for them. And I think that actually the two can work in combination, in the sense that sometimes if you are going into accessing primary care, you might speak to your GP or doctor, and them actually measuring these things like your blood pressure might actually open up, or your smoking, that can actually open up a wider conversation about your mental health. So I think it's kind of having that integrated approach, but also to address inefficiencies, to have that kind of standardized way of doing things, so that mental health isn't something that's just seen as a secondary thing. It's involved in at the core of any healthcare service. And even if someone is coming in for a physical examination, you actually take the time as a clinician to ask them how they're doing mentally, because these two things can completely impact on each other. And so that will also reduce stigma, because you're not just talking about physical health in its own kind of silo, you're talking about it as a key part of your mental health as well.
Brilliant. Thank you so much, Louise. And Ethel, are you still with us? I have 1 minute that I've been told I've used up. I'm going to steal it back anyway. Are you still there, Ethel? Yes, I think we've lost the connection. A huge thank you, Louise, Carol, Ethel, and Fiona. A really interesting discussion from my perspective, and hopefully everyone attending today found that incredibly useful. I'm going to hand back to Helen Fisher to take us on to the next part of the day. Helen, over to you.
Fantastic. Thanks so much, Lee. And an absolutely massive thanks to Lee and all of the panelists for this really wonderful and insightful session, which has highlighted many, many issues, but particularly, as is the theme of the day, the importance of supporting the physical health of those experiencing mental health issues, the bidirectional nature of those issues, and also really great to hear some suggestions about how we can provide integrated solutions and the importance of improving access. So huge thanks to you all. Really, really appreciate your contributions today. And we're now going to move on to the second session of today's festival, and we'll continue with the topic of premature mortality and mental health, but we'll focus more on suicide in this session. So this session will be chaired by Rina Datta. Rina is a very valued colleague of mine, but also a clinical reader in suicidology and psychiatry, and a consultant psychiatrist at King's College London and the South London and Maudsley NHS Foundation Trust. Her research focuses on self-harm and suicidal behaviour, and she also studies the influence of social media and smartphone use on young people's mental health. Rina also has a really strong interest in training and capacity building and does some amazing work to support the next generation of researchers. And in that context, she's Deputy Director of King's College London's Clinical Academic Training Office. So I'll now pass over to Rina to chair this session. Thanks so much, Rina.
Oh, thanks so much, Helen. And it's a great pleasure to be here today, and a very difficult session to follow, of course. As Helen has alluded to, the two areas should not really be considered entirely separately. And I think what I want to emphasize at this point is premature mortality is not really distinct from the area of suicidal behavior, which we're going into. And we should keep the messages of these two sessions really aligned. Mental health issues, as you all know, can lead to risky and self-destructive behaviours, and other associated illnesses too, such as addiction and alcoholism, which can all impact on risk of suicide, as well, of course, as the physical and mental health interplay. As we go through today's short talks, I want you to think about how we can move things forward. What would need to change to make a positive impact in the status quo and to translate research into practice? Also, if anyone can think of any success stories that we can learn from, we would also be very, very pleased to hear. So first of all, I'd like to introduce Rory O'Connor, who is Director of the Suicidal Behaviour Research Laboratory at the University of Glasgow. He's a leading suicide and self-harm researcher in Scotland, and he's done incredible work into the psychology of suicide. Rory presents the award-winning MQ Opened Mind podcast, and I'm going to embarrass him a little bit by saying his most recent achievement was only announced yesterday. I'm pleased to say that he is the first researcher from Scotland and the third from the UK to receive the American Foundation of Suicide Prevention Research Award. Well done on this accolade, Rory, and over to you to talk today about road mapping sources and solutions for suicide prevention.
Thanks a million, Rina, for kind introduction. So everybody can see the main screen? Yeah, okay. Yes, all good?
Yep.
Great. So Carol Worthman has introduced this road mapping exercise that Carol and I have been co-chairing along with a whole really esteemed panel of colleagues, international colleagues, really trying to understand and prevent early mortality. And Carol, from those with mental illness or mental distress and comorbidities associated with those, and from suicide. And Carol has introduced the sort of key findings thus far from the mental illness side of things. So what I want to focus in on is what we've been doing in the context of suicide, and just give you some insights into the paper that Carol and I and others, well, Carol and I are just finishing the first draft of it today. Literally, we'll be finishing it soon after this call to disseminate to our advisory colleagues and co-authors and get it hopefully off for submission very, very soon. But Carol described this road mapping process as a really interesting way of engaging people, experts, a whole range of different types of experts, and as well as those with lived experience, expertise. And what we asked people to do was to answer questions or think about suicide and suicide prevention in terms of these three questions that I've outlined on the screen here. First of all, why people become suicidal. And then a second one is looking at this transition, because we know about a third of people who have thoughts of suicide make the transition from suicidal thoughts to suicidal acts. And then sadly, about 708,000 people each year die by suicide. And then the third bit of when we're doing this road mapping exercise was to get some sense of why people think, or why people who are suicidal do not get the help that they need. So as I say, Carol's already described the road mapping process, but what that gave rise to across those three domains, those three questions I've just highlighted, were 550 separate responses. And what we tried to do then as a sort of organizing panel who are involved in this was to divide those factors or those issues into a meaningful way, because we can't deal with all 550, so we had to prioritize them. And so I'm just going to pull out a couple of key findings in a couple of slides time. But it's just this first one here just gives you an illustration of why do people become suicidal. And what's interesting again, that when we think even about such a specific question there, like why do people become suicidal, ostracization and stigma emerged, which also emerged in the mental illness domain as well. So it's really important to look at these commonalities. Structural inequalities, also a key issue. Trauma. And then when we ask questions then around the transition from thoughts to acts and from why people don't get the help that they need, a whole range of factors, some of them less surprising than others. But key factors like understanding the role of impulsivity, understanding the role of access to means of suicide, understanding inaccessible services, mental health services, and really services which aren't tailored to the needs of those who are most vulnerable. So for example, men. And then this issue of siloization or siloizing of treatment in terms of physical and mental health. And again, that emerged both for the suicidal questions as well as the mental illness questions that Carol touched on. So what we then did was try to bring this down, really distill this down into 12 key risk factors and mechanisms, which we think are absolutely vital if we're trying to understand and then prevent suicide. And again, I'll just pull out a couple of examples. So I'll mention down here at the bottom left here is media and social media exposure, because we know that media reporting is associated with suicide risk. So again, it's trying to think of ways or examples nationally and internationally where we've successfully engaged with media and media organizations. And although the role of social media itself, the role of that on suicide risk is probably small, it can be absolutely devastating for an individual who's already vulnerable. The role of stress and the body stress response, how we live in a society where there's inequality and disadvantage, and so many people now, when we think about the cost of living crisis, are more vulnerable. Those issues are emerging as well as basic homeostatic function, trying to tackle sleep, trying to look at how can we improve nutrition and diet and promote exercise. So there's lots of different factors. And the last one then, just to note on this, was the role of multimorbidities, because we know that suicide risk is elevated in individuals who have experience of both physical and mental illness or health problems. And again, as Carol noted, these factors cover the whole span of intervention, from prevention right through to treatment and across the lifespan. And what was clear time and time again was the importance of looking at an interdisciplinary perspective, looking at global diversity, of course, and as I've said already, inequalities. So those are the factors. I want to just say a few words then about where we got to in terms of solutions. So again, as Carol's noted, when we looked at the solutions and in terms of the number of solutions just for the suicide questions, there were 320 solutions which were initially suggested as part of the road mapping. And then what we've done is combine those, or distill those down to 3 overarching principles. The first one here is integration of mental and physical healthcare, which again, what's been mentioned in the earlier symposium, and 2 others, as you'll see in a second. And again, across those 3 principles, I think in total there are 18 overarching factors. And just to highlight for the purposes of suicide and suicide prevention, which is important, is access to primary care services with the capacity to treat mental and physical health problems. And that's vitally important because we know that although, for example, the United Kingdom, less than 30% of people who die by suicide are in contact with mental health services in the 12 months before they die, between 60 and 80% are in contact with primary care. So we need to do more refining, reorganization, reformulation, make it better so that primary care services can play an even more vital role in suicide prevention. And just give you a couple of examples on the other 2 principles. So again, this optimization of intervention synergies, recognizing that we need multi-level responses. And there's really great examples. Just looking at that first bullet point, action to reduce income inequality, such as income support and acute transfer, cash transfer interventions. So again, there's work from, for example, Brazil, really fascinating work showing that those, if you can do those acute cash transfers, is associated with reduced suicidal risk. And then the last one I'll just say in terms of this slide, and then I'll just move on to my very final slide, is we need to do more about understanding the interplay between biomarkers and other psychological and psychosocial risk factors. Because again, we probably spent too long being reductionistic. And I think that although, yes, it's been great to see the advance of AI and other machine learning techniques, but it's finding those in a way which are not only theoretically useful, but clinically important. And that's a vital challenge for us moving forward in terms of solutions. And then just for my last slide, the third overarching principle of prioritization of prevention while strengthening treatment. And it's not, again, an either or. And what really came through time and time again was the importance of early intervention, the importance of taking a lifespan perspective, looking at the devastating impact of trauma, of war, of violence experienced early in life. And then looking at things like decriminalization of suicide. And one of the strongest evidence bases we have in the field of suicide prevention is that we can restrict access to the lethal means of suicide, we can prevent suicide. And really, really clear data from Asia looking at that in that regard, restricting access or banning pesticides saves lives. And then one very last approach or last comment is that last bullet point. It's the importance of recognizing that, yes, we have an evidence base now for psychosocial treatments which are effective for reducing suicidal behavior, but we don't know who they work for. We don't know whether they work for men. We don't know whether they work for people from different ethnic minority backgrounds, never mind a whole range of other inequalities or other groups of people who might be vulnerable. So the challenge moving forward is, this is really exciting. We've been able to distill all of this work, and we hope that when we get the paper published, it will really drive forward the research, not only the research, but the policy and practice agenda, which hopefully will help to save lives. Thank you.
Thank you so much, Rory. We'll need to move on now to Ahmed Hankir. Ahmed, do you have slides for today? Just as Ahmed comes into...
No, I don't have any slides. I'll just put my video on.
So Ahmed is a mental health campaigner, a researcher and a psychiatrist working for the NHS at South London and the Maudsley NHS Foundation Trust. He's currently an academic clinical fellow in general adult psychiatry at King's College London. And I'm so excited to hear him talk because he's very passionate about challenging mental health stigma. Over to you, Ahmed. You're going to talk to us, I believe, about the life-saving power of storytelling.
I will be, yes. Thank you so much, Dr. Dutta. So I'll just dive in. So I'm Dr. Ahmed Hankir. I identify as a wounded healer. I'm both a mental health care provider, so I'm an NHS psychiatrist, and I'm a mental health care receiver, a psychiatric patient. Now, I realize that revelation may make some people feel uncomfortable. If it does, ask yourself why. You see, there's a perception that doctors should be invincible, but the reality is that we are human beings we are fallible, and we are also vulnerable to developing mental health problems like everyone else. Now, stigma and a culture of shame are formidable barriers to mental health care services. And consequently, many people, especially doctors with mental health problems, continue to suffer in silence despite the availability of effective treatments. I repeat, many people with mental health problems continue to suffer in silence despite the availability of effective treatment. Now, if that was physical health, there would be outrage. But because it's mental health, there's a deafening silence. Now, I have felt the fire of stigma, so I know firsthand how harmful and hurtful stigma can be. And so I have decided to devote and dedicate my life to campaigning against stigma and to raising awareness of the egregious effects of stigma. Indeed, the consequences of stigma can be fatal. Dr. Daksha Amson was a loving mother and wife and a brilliant psychiatrist. And she tragically killed herself and her baby daughter Freya during a psychotic episode. An independent inquiry into her death concluded that she was victim of stigma in the National Health Service. Mental health related stigma is rampant in the NHS. Succinctly put, stigma is killing people. Stigma is killing people. Now is not the time to be quiet. We must do everything in our collective power to challenge stigma whenever and wherever we see it. How do we do it? How do we reduce stigma? Well, according to the Lancet Commission on Stigma and Discrimination, launched recently, the most effective way of reducing stigma in adults is through social contact with someone living with a mental health condition. Why? Because when you meet us, you discover that we are law-abiding, community-serving, peace-loving citizens, and that we have hopes and fears and strengths and dreams. Like everyone else, you discover that we are human beings. And so the evidence is clear. People living with mental health conditions have the power to reduce stigma and must spearhead anti-stigma campaigns. Nothing about it without us. We can speak for ourselves. We have voices, and we will be heard. We must amplify the voices of people living with mental health conditions. And people living with mental health conditions must be involved in the design, development, and delivery of mental health care services at all levels. And we must harness the colossal power of storytelling. And so this is my story. When I was a medical student, I woke up one morning to discover that my hometown in Lebanon was bombed and that hundreds of people were killed overnight. And my nightmare turned into a reality. My world turned upside down. I saw harrowing and horrific images of dead bodies strewn on the streets of Lebanon, dead babies being removed from the rubble. And I reacted. I felt powerless. I felt overwhelmed. And I developed a severe episode of psychological distress. However, debilitating though the symptoms were, the stigma was far, far worse. I was ostracized, shunned, and dehumanized even by those who I thought were my closest companions at the time when I needed care and compassion the most. I received ridicule and rejection instead. And in my isolation and despair, I contemplated ending that which is most precious, human life itself. However, I resisted the urge to act upon these suicidal thoughts because suicide is forbidden in Islam. So my faith was a protective factor and deterred me from ending my own life. I eventually sought informal support from my imam in my local mosque, and he urged me to seek professional help, which is what I did. And I co-produced a care plan with my psychiatrist. I eventually recovered. I resumed medical school with renewed determination and resilience. There was a fire, there is a fire burning in my belly and thunder in my heart to realize my potential and to make important and meaningful contributions to our world. And I finally qualified. However, my journey had only just begun, for I had been ridiculed and humiliated for so long. I was inspired to work above and beyond the call of duty. And I was fortunate to receive the 2022 World Health Organization Director General Award for Global Health for my contributions to advancing global health. My story is further evidence to prove that people living with mental health conditions can not only recover, can not only function, but we can achieve excellence. So I invite you to stand in solidarity with us, to contribute to a cultural revolution that empowers, dignifies, and humanizes people living with mental health conditions. Because if I can recover and realize my dreams too, then with the right support, other people out there living with mental health conditions can recover and realize their dreams too. Thank you.
Thank you so much, Ahmed. That was so impassioned and incredibly revealing. Thank you for being so honest and sharing that with us. And it leads very well to our next speaker, who's going to be talking about suicide prevention in healthcare workers, a global call to action. Let me introduce Lai Fong Chan, who is an Associate Professor of Psychiatry and a Consultant Psychiatrist at the National University of Malaysia. She received the 2017 International Association of Suicide Prevention De Leo Fund Award and is currently their third Vice President. She is a member of the World Health Organization's Strategic and Technical Advisory Group on mental health, brain health, and substance use. So over to you, Lai Fong.
Thank you so much, Minu. I'm actually collecting my thoughts as I slowly digest the powerful words that Dr. Ahmad Hankir just shared. It resonates very personally to me. As I am just beginning my journey to share on a more public space my own living experience with depression and anxiety. So Ahmad, I just want to say today that your story is absolutely evidence-based as a really powerful advocacy tool for especially healthcare workers to come up and say that they are not okay. I don't have slides today, and I was struggling to figure out what can I add to this panel. On a daily basis, I struggle with having to see medical students from my own faculty as clients. And on the other hand, I struggle with the conflicts that are really challenging because we have to kind of still, quote unquote, report back to our faculty administration. How is this medical student doing? Is he or she fit for medical practice? Is he or she fit to become a doctor? Now you may be appalled. Why is it that we are put in this position where not only are we having to provide mental health care to our own medical students, but having to answer the difficult question, is this medical student fit to be a healthcare provider in future? I myself struggle a lot as when I listen to the stories of my clients who are medical students, I sometimes get overwhelmed with anxiety as it triggers back my own struggles and start to question my own credibility and capability. So, Ahmad, I cannot say how much your story is so powerful, especially from where I come from, where I'm sure globally the stigma to mental health is so incredible, but especially so in Malaysia, where we are still coming to terms with giving the same status of mental health if we compare it to physical health. As a healthcare provider, we have access to the knowledge and access to means that can be extremely little if we are in a crisis and do not have anywhere to turn. How are we going to manage that knowledge so that it goes on to heal and not be used in a crisis are huge question marks on how to improve the safety of healthcare providers. I also want to touch on the effects and in the impact of the pandemic. One upside is that it has brought to the forefront, and I think it has given a voice and normalized the expression of distress, that healthcare workers are not immune to mental health conditions. Healthcare workers have been exposed to extreme trauma when they are put in positions to literally be forced to triage who lives and who dies in the face of extreme limitations of resources. I'm not sure that we have completely recovered from this moral distress and moral injury, but I have hope that moving forward, especially with the power of lived experience and advocacy, post-traumatic growth can be birthed, stigma can be busted, and that it will not be so feared for healthcare providers to come up and seek professional help, and that they will not be punished for coming to seek help, but they will be well supported and in fact well provided for, and that all of society and policymakers and legislation will mandate that it will be the right of everyone, including healthcare workers, that access to personalized quality mental health care and societal support is key and crucial to maintain the integrity of our healthcare systems. Thank you again, Ahmad, and I will definitely stand in solidarity with you. Thank you.
Thank you, Lei. Bless you.
Thank you so much, Lai Fong, Ahmed and Rory for this series of talks. And before we move on, I would actually like to bring in our research advisory group member from DataMind, Michael McTurnan. He's going to join us for the panel discussion. Hello, Michael.
Hello.
Hello there, hello. Thank you for joining us. So, Michael, I understand that mental health has been both a personal and professional matter for you. I believe that your struggle with anxiety, insomnia and neurodiversity has obviously influenced your life as well as your work, and the impact that mental health issues and suicide have had on Michael, his friends and his family led him to train as a counsellor, and now he also works part-time in the NHS. So I'm really grateful that you could join the panel today to give the lived experience and the survivor perspective as well. So I'd like to hand to you first, if I may. You've obviously heard these very impassioned pleas from your perspective as someone who's survived suicide. What is your feeling about how we can move forward? Are there ways that we can manage things better in the future, or prevent suicide in perhaps ways we haven't thought about as yet?
Good question. I mean, first, what a series of speeches, and I think that even just listening to Lai and Ahmed talk, you know, I could feel my emotions rising just listening to that, because it's a really personal topic, and it's a really difficult topic to talk about, because we don't talk about it. And I think there's something there about being open and being vocal, but equally on the other side, clinicians and services listening to what we have to say, listening and believing and valuing, perhaps, you know, what it is that we're saying and how it is that we're feeling. And Rory was inspiring, you know, the passion to describe a framework towards resolving some of these issues. And I suppose my reflection on that, and maybe a question, is sort of how can we implement something like that when we have such an NHS under such strain? We have very little money. In fact, I work in an enormously deprived area in the NHS, and a GP surgery as a counsellor. We're one of only 2 GP practices in Edinburgh, and possibly the Lothians, that have counsellors. And if we talk about integration with physical and mental health, we talk about having, you know, people in primary care to work with people who are, you know, experiencing suicidal ideation, then surely there has to be more of a connection. But how, you know, given the constraints that we have, it's not I think we know the what, perhaps, and we have the passion, but how do we do this? How do we make this a priority? How do we do this? And how do we do it quickly before more people fall between the cracks?
Absolutely. Thank you for starting us off there, Michael. You raised some very valid points. May I go over to you, Laifong? What are your thoughts on how we can move forward with the agenda? You were also it was good to hear about your practice in Malaysia and working with medical students in particular, but not just in healthcare professionals, in the general public as well. How can we begin to make changes in this important area?
I think there is, I think we cannot overspeak about breaking the barriers down to accessing services that one needs and the stigma. Maybe I'll just kind of highlight that a lot of what we know as psychiatric care and psychiatric services are very Western-centric. And our diagnosis that psychiatrists use are absolutely Western-centric. So there was a podcast that I was doing with a colleague, me and Rory, about suicide prevention in low and middle income countries. And we kind of circled around the question, a really fundamental question of what does depression, what does being in suicidal crisis mean, and how is it expressed in different cultures and different languages, whereby sometimes there are no accurate words to actually translate into suicide, or the word suicide is so taboo that it cannot even be expressed in a culture or in a particular language. So I think that beyond just trying to figure out how can we sort of like improve existing mental health care services based on the evidence that we know, I think we really have to come back to really fundamental concepts about how does an individual, in the context of their culture, their society, their family, how is distress expressed, and how is that distress received when it is expressed? And how can we capitalize on the existing structures and models in a particular culture and society to leverage on that, and not just think about, okay, someone's not well, let's just refer them to psychiatry or mental health services. What about the religious communities? And Ahmad has spoken so much about how his faith has been fundamental in his journey and his recovery. And Aminia has put really wonderful comments about how neglected the whole area of religion and spirituality. And I want to say that my faith is a huge dimension in my recovery as well. But sometimes I think we feel that it may not be the most politically correct thing to talk about religion and spirituality, because it is sometimes divisive and it is sometimes polarizing. Religiosity or religious attendance have been shown in evidence, particularly in healthcare workers, to be a protective factor. But we also know, and I've also been involved in research, qualitative research, whereby religion is not such a straightforward construct. On the other hand, if the idea or the concept of religion is communicated in a very judgmental manner, that can be extremely counterproductive, and they may even increase the suicidal distress that someone is feeling. So I think we really have to have a conversation about how do we get comfortable in each unique individual and their cultural identities to look at things like religion and things like culture. How is that going to be supportive in one's mental health recovery?
Thank you, Lifelong. And I think I'd like to add from my own clinical experience as well, that sometimes those who perhaps are agnostic or atheist, there can be other factors such as loyalty and need to care, for example, for pets. So as a practitioner, I often sort of inquire in my patients that are suicidal about, those sorts of features that might be really critical in their staying alive. For example, not having somewhere to rehouse a dog or a cat or a rabbit in one of my patients' cases. Rory, did you want to comment on this area of suicide prevention?
Yeah, I've got two comments, one on Michael's point, and then I'll take Lifelong's. But just to begin, just huge thanks to Ahmed, Lifelong and Michael for the really powerful contributions, and so central, and Lifelong knows we've been working on the Gone Too Soon program. That lived experience is central to everything that we're trying to do and achieve. Maybe taking Michael's point first, because Michael, I totally agree. The challenge we have, and it's going to get even worse, when the mini budgets were finally announced, no doubt, in the United Kingdom, but I know we're looking globally as well. But so there's two things I would say to that. There is evidence that actually from low middle income countries, actually there's a study we're including in the Gone Too Soon paper, which shows that integrated care saves money, right? So it's trying to build these policy arguments, never mind the moral, ethical argument about we should be providing tailored care to the needs of people, but rather that there is evidence that integrated care saves money, right? So it saves, so I think that's an important argument we make with policymakers. And then another one, which I always find a bit challenging to make, is that that we want to prevent every single suicide to prevent distress, the families left behind, those people who are suffering. But and so that's the moral imperative, but there's also the economic case. And the economic case for suicide prevention is also enormously clear. It's now estimated that the health economists estimated that every suicide costs on average about, these are data primarily from Western countries or high income countries, but costs about £1.5 million. So again, we're trying to make the argument to policymakers and people in health and social care partnerships and the like, is saying, actually, never mind the moral question, this will save you money. So I think we have to also be upfront making these economic arguments alongside the humane arguments. And then on Lifelong's comment on, I couldn't agree more. And obviously Armenia is on the call, and Armenia does fantastic work looking at the role of culture. And again, that's something we touch on. It's in the paper as well, looking at the global responses. And I think that, and Rena, you mentioned the point about, so it's not necessarily just religion and culture. It's looking at what is meaningful to an individual. What's a sense of connection, belongingness? What is important to the values? So it's tapping into the values of each individual, and that's obviously culturally done, as well as looking at us as these holistic beings, not reductionistic. So I couldn't agree more. But I think the issue with the religious issue isn't straightforward, though. If you look at the evidence, different studies show different things, and that's why it's important to really, this personalized response is key.
Thank you. I'd like to bring in Ahmed, please.
Oh, thank you, Rena. I'm really humbled and touched. I'm feeling the love, actually. Thank you, Michael. Thank you, Rena. Thank you, Rory. And thank you, Lay. Um, I mean, I think a lot of kind of thoughts, feelings, emotions, multiple ingredients. We have people from different backgrounds, and I think that's really important when we want to reduce stigma. I think the more kind of diversity we can get, to emphasize, people from different races and different genders, and I guess different identities. I think for me, it's like listening, trying to learn, sharing. I think the language that we use, for example, and a lot of people use disclosure. I think that has criminal connotations. And living with a mental health condition, it's not like there's nothing criminal about it. So trying to calibrate our words carefully. People usually say lived experience, but I mean, and you feel as though you confine it to the past when you say it's lived, as if it's behind you, and it's like, well, no, I'm actually living with a mental health condition. So I don't even take it one day at a time. I take it one moment at a time. And it's interesting how something can be, I guess, a protective factor for one person and a risk factor for the other. So we can see, for example, some people have commented on how religion is a risk factor to suicidal behaviors. I mean, so what does religion mean to the individual? So really kind of emphasizing what Rolly said about, I guess, having a personalized approach or an individualized approach. And what I love about Lay and Michael is that the emphasis on individuality, on embracing vulnerability, of, I guess, how empowering and dignifying it can be to share our stories and to disseminate our message of hope and recovery. But just because it's empowering and dignifying for me, it doesn't necessarily mean that sharing for other people is empowering and dignifying for them. So we know that Patrick Corrigan had developed the Honest, Open and Proud manual, HOP, and it helps you to answer questions like, is being honest and open right for me? And if it is, what do I share? When do I share? Who do I share to? So I mean, I love Dylan Thomas. He's my favorite poet, and I've adapted his poem. Do not go gentle into that good night, but tweet against the dying of the light. This is the digital technology, and we need to harness the power of social media. But I think for me, like, the take-home message is that people living with mental health conditions, we are often at our most vulnerable, and we are human beings, and we feel like we are being dehumanized and even brutalized. I don't think that's an exaggeration. Many people living with mental health conditions, I mean, look what that happened in the scandal in the Northwest, for example. I think there was a Panorama documentary. So we need an approach to mental health that is holistic, that is grounded in a human rights framework. And I think also people say, the ubiquity of stigma. Where do we even begin? We begin with the human heart, because denial is powerful. And just because I'm living with a mental health condition, it doesn't necessarily mean that I'm not potentially a source of mental health related stigma. So I think to be brutally honest with ourselves, engage in introspection, and identify any stigma, any bias, any racism, because people of color are overrepresented not only in the criminal justice system, but also mental health care services. So is there any, and we can't turn a deaf ear and a blind eye to what people of color are saying who are open to mental health care services. They are saying that we are the victims of stigma. We are the victims of inequalities and inequities and structural and systemic issues. So really, to emphasize, the person that is receiving care from you is at their most vulnerable. And I think it's really important to listen. And we can't, I mean, this is nothing new. I guess I'm just kind of echoing what many other people are saying, but I don't think it can be said enough. Kindness, compassion, empathy, dignifying people, and also being honest with yourself and trying to identify any stigma that might be within us. Now, I'll just say real quick, there's nothing to stop us from sharing in a clinical setting. For example, the General Medical Council, the Royal College of Psychiatrists, the British Psychological Society. We know that the former president, Jamie Hacker Hughes, has been honest and open about his experiences living with bipolar affective disorder. But I think in a clinical context, it's a lot more about the person receiving care from you. And I don't ever remember sharing in a clinical context. Don't get me wrong, in a conference or in an educational context, and I'm not against it. If someone wants to know about me, I'm happy to share. But I think in that context, really, it's more about the person receiving care from you. But there is a solace in shared experience. And I know Johnny Lovell at York University did his entire PhD on this. Sharing in the clinical context. And interestingly, providers, the thing that they were least likely to share was their experience living with a mental health condition. And receivers, what they wanted to know about the most was any experiences of living with a mental health condition. So I think there's some kind of maybe confusion and reluctance about what's happening in the space. But yeah, those are just, I guess, some of my initial thoughts. And yeah, thank you so much again. So much synergy, yeah.
Thank you so much for all those comments. I'd like to move on now to something that's been in the chat and people have been pondering as you've all been speaking. It was raised originally by Leah, and it's the disconnect between mental health and drug alcohol recovery services in the UK is vast, and early mortality from drug addiction has taken huge leaps in the last 12 months. Rory, can I start with you to ask, how can we take the lessons from the gone too soon process to challenge this systemic issue?
Well, what we're hoping, what will not necessarily specifically with looking at drug and alcohol, again, that is mentioned, we talk about that obviously in the Gone Too Soon program because it is such a huge issue. But what we're trying to do with it, which hopefully will help move things forward, is we're trying to provide the evidence, first of all, and the consensus from experts across discipline and across country to show actually there are ways of doing things differently, and that these ways of doing things differently lead to better care, better outcomes. So I think, and then, because it's often, and the challenge is convincing people that it's beneficial to work differently. I know, if I just give one example, slightly different example from Scotland, I've been heavily involved in what's known as the distress brief intervention based work in Scotland. And what we were concerned about was, as a country and at a sort of governmental level, it came out of the suicide prevention work that I do. We were concerned that too many people were falling through the cracks who would come to emergency department, for example, get in contact with the police. They were in distress, may not be acutely suicidal, but they weren't getting help or support. And so what we thought, well, what can we do differently to make sure that those people, that we have an integrated service, a new response with no waiting list, a new way of working to help those people. And basically the biggest barrier I think we had was we were trying to bring all these different partners together, and there was a lot of skepticism. It looked like it's another new initiative by government. It's another that they'll try it for a brief period of time and then they'll abandon it. And so we had to really overcome. It started in 2017, a lot of work bringing together partners who'd never worked together before, the third sector, so the voluntary sector plus statutory services, plus clinical services, as well as the police and so on, social work. But what we learned was if we could demonstrate, really, we had real champions on the ground and we demonstrated that this would work. And then the independent evaluation, which was just published this year, has shown it's been really, really beneficial. So I suppose my message then would be how we learn is we demonstrate on the ground these small, changes so you can make these, if you tried initially, I was in a local context initially, that there are new ways of working, and there are these really human reasons why often systems don't work, and then move it forward that way. So I think it's having that advocacy role. And I just think we learned so much in Scotland, and now it's nationwide, almost, this program. And we had a meeting just before I joined this call, and over 32,000 people have gone through that service. So it really can make a difference, but it's overcoming our inherent biases and concerns and trusting and working together collaboratively. And at the heart, and just Ahmed said, highlight, and I forgot to mention my brief comment earlier about the importance of compassion. And the whole distress brief intervention program is called, the ethos is compassionate, connected support. That's what it's all about. And we can add that to all aspects of mental health care. It'd be really, really helpful.
Thank you so much, Rory. Does anyone else from the panel want to comment on this, or indeed anyone in the audience as well? Michael?
I would just add, Rory's spot on. I would just add to that. I think there's a real danger that quite often that we go, we avoid working with people who are drunk or drug users, because we just think, well, that that they're a drunk, they're a junkie, they're, and they're difficult to work with, right? So it's much easier for me to go and work with these people over here, but that fails to, I mean, it's like warning lights, right? Isn't it? If someone ends up in A&E because of something that's happened when they're drunk, there's probably undertaking behavior that's unsafe and potentially classed as self-harming. But because we don't want to, because we stigmatize those people, we don't want to work with them. And I think it's really important that we, sometimes the people who are angriest and most difficult to deal with are the people who need our help most. And if we are so quick to stigmatize them or so easy to avoid them because they're more difficult, then I think we miss a great opportunity to support people.
Thank you, Michael. Either Ahmed or Laifon?
Yeah, maybe I'll just like to add a bit, perhaps in a more clinical context. Absolutely that intersectionality and the combined sort of like, how do we integrate services to be more friendly and to be more compassionate to the client, to the end user. I mean, from my own experience, the emergency department is usually the sort of like go-to place for a person in a crisis, in a mental health crisis, to land. But it's absolutely one of the most horrendous experiences for a person in mental health crisis to land in emergency services. We've had so many stories of clients who come through the emergency services for the lack of, any other channel to access help through a crisis. So I think we really, really need to think about how to have more compassionate, friendly services in the community, whereby somebody in crisis is met at their time of need in a compassionate manner. I've had clients who were in the throes of a crisis and an attempt and saved, who had really distressing encounter with first responders. But on the other hand, we've heard from stories from first responders how awfully they're traumatized when somebody they're absolutely trying to save, they lose them. And so, we're talking about capacity building, we're talking about how do we do post-vention work in first responders. We're thinking about if there's just not enough people in emergency services to be able to just handle all the other different medical emergencies and physical emergencies, we're just not going to make things work. So how are we actually going to do that? I think it's still a really big thing, which is a work in progress.
Thank you. Ahmed, did you have any final thoughts?
Wow. I was thinking about, I guess, suicide and globally. I know that every 40 seconds, someone somewhere out there dies by suicide, tragically. But if I'm not mistaken, and this is Rory's area of expertise, I think most suicides actually occur in low and middle income countries. I think, 80%, I think, if I'm not mistaken. And so perhaps that would, we talk about this pervasive treatment gap. Only 10% of the health budget is allocated for, 13%, sorry, for the provision of mental health care services in the UK. Actually, that's pretty good compared to other countries where I think it's 1%. So this kind of huge disparity of esteem and stigma at the level of policy. But some other kind of thoughts that crossed my mind as well. I guess, the male to female suicide ratio is 3-to-1, and this kind of toxic masculinity that permeates our societies. The infiltration of stigma into clinical care. So we know that diagnostic overshadowing, for example, I think kind of contribute to that mortality gap. And I think it was very powerful what Rory said. I think only 30% of people who died by suicide were in contact with specialist services 12 months, within 12 months. And was that 80% were in contact with primary care? But I think that it's such a huge issue that it concerns everyone. And I think it's people providing the informal support who play such a massive role in suicide prevention. And as Rory said also in his talk, social media might seem like it's playing a minor role, but it's the people who are most vulnerable, because it's at our fingertips, isn't it? Everyone, we're addicted to our devices and social media. And I guess the take-home message here, in a world where we can be anything, be kind. Because and it can be that negative, nasty tweets that can push a vulnerable younger person over the edge. So I think I'm really, I guess, that's my clarion call. And again, it might seem disingenuous, but I think we can't emphasize it enough. In the world where we can be anything, let's be kind.
Thank you so much, Ahmed, and all the other speakers today. So Rory, Lafong, and also Michael for joining us on this panel. We have covered some very sensitive topic areas which you may have been affected by, and our MQ team have very kindly put in links in the chat which you could go to for sources of support should you so require. I'm now going to hand back to our chair, Helen Fisher.
Thanks so much, Rena, and absolutely huge thanks to all of the panel for this unbelievably powerful session and for all the fantastic suggestions you've also made about how we can really positively change the current situation to support those experiencing mental health difficulties, to prevent them contemplating and dying by suicide. So really huge thanks to you all for sharing your experiences and for all these really useful ways that we can hopefully move forward together. So we'll now move on to the poster session. And this year, MQ has organised a creative way for our poster presentations to try and make the research more accessible, which is in the format of TikTok videos. So we're now going to watch 2 of these. So if you can just sit back and enjoy, that would be fabulous.
Did you know that people like me die approximately 10 to 25 years earlier than the general population? And it doesn't matter what race a person is or where they live? Scientists have said that bad health behaviors like eating bad foods, not exercising, or smoking cigarettes is the reason why people like me die young. I don't buy it. Because after billions of dollars and decades of research dedicated to the development of interventions and disseminating evidence to address this health disparity, the mortality gap between those with serious mental illness, like me, and the general population is increasing. A new paradigm is needed. I worked along with others to develop the first ever lived experience research agenda to address this health disparity. We met over Zoom for 2 days. Our group included 40 people from around the world, including service users of the mental health system, clinicians, scientists, policymakers, and media outlets. About 60% of those involved had a lived experience. First, we learned about this issue, and then we partnered with one another and brainstormed a solution to this problem. After the 2-day meeting, we were asked if we agreed with others' ideas, and here's what we came up with, starting with the most important. First, that we need an empirical understanding of the direct and indirect social and biological contributions of trauma on early mortality. Addressing trauma needs to be included in programs, including trauma caused by the public mental health system. 2, advance the role of family support, extended families, and informal support. Families can be a lifeline and support people with a lived experience. 3, redefine clinical education and support clinicians with technological advances to improve diagnostic accuracy. There's been a lot of misdiagnosis of medical conditions among people like me. Let's support clinicians in accurately diagnosing people. 4, realizing the importance of recurring disorders and early mortality. 5, redefine the term social determinants of health to include outcomes meaningful to people with a serious mental illness diagnosis, such as loneliness and sense of belonging and sense of community. Let's look at the things that we think are the cause of early death, like loneliness. 6th, precision medicine. Precision medicine can inform treatment. We are all different. Intervention should be personalized for us. And finally, 7, redefine the terms system literacy and health literacy. Findings from research need to reach people like me, not just scientists. I can help. For more information, please check out our website at livedexp.org. Thank you.
In our study of people with severe mental illness in South Asian countries, we found that people who ate at least 5 fruit and vegetables a day had 2.5 times greater risk of being overweight or obese. Severe mental illness, or SMI for short, is a term used to describe a number of different conditions, including schizophrenia, bipolar disorder, and severe depression. We know that people with SMI die on average 10 to 20 years earlier than the general population, and research suggests that a lot of this is down to people being obese. We think that people with SMI from low and middle income countries are at an even greater risk of obesity, but a lot of the research in this field is actually from higher income countries. The aim of our study is to fill this gap in knowledge and to try and understand more about obesity in people with severe mental illness in the developing world. A total of 3,989 participants agreed to take part in our study, and they came from Pakistan, India, and Bangladesh. We measured their height, weight, and waist circumference, and also did a survey to collect other important pieces of information like their age, gender, job, income, other health conditions, and also information about smoking and drinking habits. We used their height and weight to calculate their BMI, and then carried out some statistical tests to try and find out if there was any association with a very high BMI or obesity and any of the other factors we've mentioned to find out how strong this link could be. Our study found that 17.3% of participants were overweight and 46.2% of participants were obese. We found that the risk of obesity was more than double in women with SMI compared to men with SMI. And we also found that there was a 37% greater risk of being obese in the highest income category compared to the lowest income category. But one of our most interesting findings was that those who ate more than 5 fruit and vegetables a day had 2.5 times greater risk of being overweight or obese. Now, we're not sure about the exact reasons for this, but we think it might be due to the fact that people who can afford more fruit and vegetables tend to eat more food in general, including unhealthier foods, which inevitably leads to weight gain. Now, this is in opposite to what we might see in developed countries where people with less income can't afford healthier foods and tend to be more overweight. These findings highlight the burden of obesity on people with SMI in these countries, and it has also helped to identify the groups most at risk of obesity, which means that governments and health services can prioritise their help towards these people and maybe even increase the life expectancy of people with SMI in South Asian countries.
Absolutely massive thanks. I'm going to give them a clap because no one else can, to both of our TikTok presenters for creating such wonderfully engaging posters to share their fantastic work on premature mortality and mental health. I'd also like to extend again a huge thanks to all of our chairs and panelists today for the fantastic, passionate and thought-provoking discussions. They've underscored how crucial it is to tackle mental and physical health in an integrated way due to the absolutely horrendous premature mortality experienced by those living with mental ill health, and how important it is to improve access to appropriate care as soon as people need it. Absolutely crucially, we've heard how people's own experiences, cultures, and contexts must be central to this, and that research and services need to be co-produced and support absolutely must be personalized. Also, as has been common across all days of this festival, we've also heard how essential it is to tackle social and economic determinants of health in order to reduce comorbidities and distress. And following on for the powerful session today, I really hope you will join us all to tackle mental health stigma and find ways to prevent premature mortality. So before I hand over to Lee to tell you about the Zoom discussion meeting, I would like to encourage people to complete the feedback form. This will hugely help us to improve and shape future events at MQ. And I'd also like to encourage you to share your reflections and takes on the presentations and discussions today on social media using the hashtag MQ Science Festival. If you've missed the other days of the festival, you can watch the recordings on MQ's YouTube channel, and we'd be grateful if you could keep sharing these with your networks. Also, don't miss tomorrow's session, where we will be discussing career paths in mental health research, and we'll also have dedicated time for breakout rooms where you will have the opportunity to discuss your career options with experts. So I'll now hand over to Lee to tell you more about how to join the Zoom meeting to carry on this fantastic conversation. Thanks, Lee.
Thank you so much, Helen, and to all of our speakers and panelists today. Thank you so much, everybody, for joining us today. It's been a really exciting conversation. We'll be closing this down in about 10 seconds time. We'd love to hear from you at the Zoom discussion. Take care.